Well, let's start by just talking about what are the most interesting non-hormonal medications for VMS. We're fortunate to have a new class of medication, the NK receptor antagonists, and those came into existence a few years ago, related to some really fantastic research by Naomi Rance in the last 10 to 15 years. And so we have two drugs on the market now. One is fezolinetant came on first, also known as Veozah. That was approved in 2023. And then just last fall of 2025, we have elinzanetant that came on, also known as Lynkuet. And so two options. There's a little bit of a difference between the two. The fezolinetant is an NK3 receptor antagonist, and elinzanetant is NK1 and NK3 receptor antagonist. And the difference, we believe that NK3 is mostly vasomotor symptom management. And the NK1 is probably has a little bit of an effect on vasodilatation, so can have an effect on hot flashes as well, but also has an effect on sleep through substance P. And so we think that elinzanetant may be a little more targeted to sleep specifically, in addition to vasomotor symptoms. But both drugs have been shown to be quite effective in relieving vasomotor symptoms and improving quality of life. That is such a great question. And I'm going to answer it by giving you a little background about our menopause clinic that we have at Mayo. And interestingly, of those women who are coming to our menopause clinic, about one quarter of them were found to be at intermediate or high risk for obstructive sleep apnea, and a certain percentage of those went on to be diagnosed with obstructive sleep apnea. So I think when we're seeing women in our offices who have sleep disturbances in midlife and vasomotor symptoms, we do need to think about, does this person have a primary sleep disorder and specifically obstructive sleep apnea? And I would err on the side of screening them because it's easy to screen. It's a bad thing to miss. And so, especially if someone is having primarily nighttime sweats rather than daytime sweats, and especially if they might have morning headaches and fatigue, women don't always report having loud snoring. So it's important to remember that the presentation of obstructive sleep apnea might be a bit different. So that would be for sure one situation where I would make sure we're screening for sleep apnea. Restless leg syndrome is also more common in midlife. And if you throw in there that they might have heavy menstrual bleeding around the menopause transition, they might be iron deficient. That's also associated with an increase in restless leg symptoms. So I think all in all, good to screen for primary sleep disorders during this time frame. Having said that, there's a lot of sleep disruption associated with the menopause transition. Insomnia is incredibly common. And in fact, it's estimated that about half of postmenopausal women are going to have a sleep disorder of some sort. So, so screening for these is incredibly important. So what can you get with menopause specifically? We can get night sweats that can disrupt sleep. We can just have plain old insomnia that disrupts sleep that's related to menopause. We can also have mood disorders that also disrupt sleep. So I think it's really important for the clinician to figure out what is contributing to what so that we're addressing the right things. And we might honestly treat insomnia in a different way than we would treat nighttime hot flashes. So figuring out what the primary issue is with sleep is incredibly important. Having said that, if a woman's having a lot of hot flashes, hormone therapy is a great option for many women, especially those who are under the age of 60 or within 10 years of menopause onset. And you may possibly, actually, probably get some sleep benefit in terms of relief of hot flashes, but also in the insomnia symptoms with hormone therapy.